Hello everyone, I'm Hattie Atwell-Rogers. I'm based at the Centre for Sustainable Healthcare and I'm one of the project managers on a work package in the KitNewCare project. So this afternoon I'm going to talk about SusQI in action, so how we're driving sustainable quality across Europe with the KitNewCare project. Just to start with, I wanted to give a quick overview of what the KitNewCare project is. So the project is part of the EU's key funding programme for innovation and research to tackle climate change and to achieve the United Nations Sustainable Development Goals. It aims to really transform the delivery of kidney care across Europe, and the project runs from January 2024 to December 2027. So within the project, we have 4 clinical partner sites. So these sites are all kidney centres and they're located in the Netherlands, Italy, Spain and Poland. So these centres were purposefully chosen because of the fact that they're spread across Europe, and they're also centres that have pre-existing expertise in kidney care as well as sustainable healthcare. So the work package that I'm project managing is focused on workflow and organisational optimisations. So what we're doing is identifying both novel and already researched and implemented optimisations, which we are then piloting across our clinical site. So I just wanted to give you a flavour of some of the optimisations that the sites will be implementing. So we have virtual clinics to reduce patient travel. We also have the streamlining of waste processes, so improving recycling and also reducing incinerated waste. We're also looking at reducing any unnecessary consumables, as well as sustainable procurement, and additionally looking at food-based optimization, so whether that's introducing more plant-based options within hospitals and also promoting plant-based diets where it's clinically appropriate for patients as well. And then I want to touch on how we are actually embedding SusQI into this approach. So obviously it's quite complex having 4 different sites across Europe and carrying out quality improvement projects in each of these. So what we've done is we've really based our approach on already well-established quality improvement foundations. So for example, using the model for improvement, we're also doing plan, do, study, act cycles to pilot each of these optimizations in the sites. However, we've really embedded the SusQI framework into this. And I think that's what we found so valuable about the SusQI framework, is that actually you can layer this with other quality improvement approaches, and that it's quite flexible and adaptable to different contexts and also projects of differing levels of complexities. So additionally, we've integrated SusQI tools at every step. So we're really supporting and encouraging sites to use the SusQI tools at every phase of the project. And then finally, when it comes to measuring the impact of the optimizations, we're carrying out a 4-factor outcome analysis. So we're using life cycle assessments to do this, and we'll be looking at the health, social, financial and environmental outcomes. So this is really in line with the sustainable value equation. In terms of challenges, of course, when you're working with SusQI at this kind of scale, there's always challenges that come with this. One of the challenges that we identified quite early on was to do with the language and concept of quality improvement itself. So we noticed quite quickly that the terminology and language is not universal. In some contexts, different phrases are used that refer to quality improvement, such as change management or improvement science. There are some regions where there's not a direct translation. And actually, I think the first step is kind of trying to make sure that everyone's talking about the same thing, and that sometimes even if there's not a word for it, these processes and quality improvement are taking place. Cultural and contextual variation. So of course, we're working within very different political and regulatory environments. This, of course, affects the prioritization of sustainability, but also the way that quality improvement is viewed. And additionally, I guess, how much freedom you have with the regulations in terms of how you can make change. And this, of course, also affects the healthcare culture and organizational structure. Equity and inclusion in decision making. So we found that there are, of course, variations in the patient and public involvement. So whether centres have had experience with this previously, or whether it's the norm for patients and the public to be involved in quality improvement. And then also language barriers risk silencing contribution. So within the project, we're very aware that we are English language based, but this also means that we have to be cautious to ensure that those patients and staff members that don't speak English also are able to be involved in decision making. Despite these challenges, there are of course great opportunities that come with this project. One of them is breaking traditional boundaries, so just being able to work across physical boundaries, being able to work with these different centres as well as the other partners that we have on the project has allowed for this accelerated learning and knowledge sharing. It's also given us the opportunity to actually understand the contextual impact, so what impact the context has on not just outcomes, but also process, so understanding how SusQI is taken up in different contexts. And then finally, spread and scalability. So with this project, rather than replication being an afterthought, it's actually very much part of the project. And this is supported by the fact that we're working across different centres and then hopefully spreading and scaling to a much wider field as well. So thank you, everyone. And I'm really pleased to say that we have one of our local coordinators who's going to speak next. So I will just stop sharing and hand over to Dr. Zuzanna Jakubowska.
Yeah, my slides visible. Yeah, perfect. So I'm just gonna jump into my slides. Oh yeah. So in 2024, as a part of our work on clinical pathways and carbon, the CO2 emissions mapping, we began to take a closer look at the way of our nephrology and hemodialysis department functions. And through our internal review and conversations with other centers across Europe, we noticed something paradoxical, that despite having computers running all day and electronic health record systems in place, we were still printing a huge volume of paper, lab results, prescriptions, notes, actually hundreds of pages per patient per year. And this sparked a simple question: why do we do it? And from that question, the very clear goal emerged, and we decided to make this paperless transformation one of our several workflow optimizations. And the core of our optimization was very simple. We wanted to replace paper with smart, secure digital workflows. Instead of printing the lab results, physicians now review them directly on tablets, and medical orders are entered electronically as well. And this shift was supported by infrastructure improvements, including stable Wi-Fi and integration with our hospitals' electronic health records. And we are obviously not stopping there. Phase 2 is currently underway, implementing electronic signatures to fully eliminate paper from our daily documentation. And the transformation is just this paper and printing is also about saving time and letting staff focus on what really matters, the patient, not printing documentation. Once we went paperless, the benefits became very, very clear, and they matter even more when you consider our scale. At our dialysis unit, we care for over 90 chronic hemodialysis patients, and we perform over 1,000 hemodialysis procedures per month. And each treatment comes with medical orders, signatures, lab results, and documentation. That's a tremendous amount of paperwork, and most of which actually ended up unread, uncollected, or repeated. So by shifting to tablets and digital works, we drastically reduced our paper and toner consumption. Financially, the savings go far beyond paper, as I said, because we also cut down on hidden labor costs, like time doctors used to spend printing, signing, analyzing, filing this documentation. So in fact, just because actually just printing and reviewing lab results used to consume a full specialist workday per month, every month. So it was a huge amount of time. And the new system gave us faster, more reliable access to patient data and improved the communication between our team members, but also with patients. And most importantly, it gave us much more time, and we see that already. As with any transformation, there were challenges, both technical and human. One of the first barriers where we encountered was resistance from our senior staff. For some older doctors, using tablets felt unfamiliar and actually disruptive. Years of routine habits are not easily replaced with touchscreen tablet. But we also faced technical issues, especially early on with our Wi-Fi interruptions and delays in the syncing reports. But these were eventually resolved, and they didn't slow us down. And we also have the regulatory barriers, as they mainly appeared as we are preparing for phase 2, which is the electronic signatures. But actually, I would say that the most important difficulty wasn't technical, it was rather strategic, because we need to rethink our entire documentation system, and we needed to ask ourselves, is that particular change really improving care, or is it just making it look modern? So it's actually the question that continues to guide us in the whole transformation process. And what's next? So while we've completed phase 1, we are from finished. The next major milestone are obviously electronic signatures, but we also are preparing the comprehensive analysis of feedback from both staff and from patients. And all of the surveys we collected, I hope they will help us understand the satisfaction levels, what are the disadvantages and advantages of this change. So we are obviously going on, and thank you for listening. This was my perspective from our clinical side.